Hopefully.
Oh, no. Good afternoon, Dr.
Okay, hi.
Did you manage to see my
Hi,
email
everyone. Hi,
yesterday?
Dr. Richard.
Can you hear me?
Yes.
Can you hear me?
Yes,
Okay,
I
now I
hear
got to
you.
figure out if I can. Okay, now I got to figure out to share. Hi, everybody. All right. So, sorry. Been running around. I'm not in the hospital today, so I'm trying to do this from my home office, which I've never given a talk from here before. So I'll do my best.
It is
Good to see you,
very
Richard.
clear voice, no problem.
The picture's a little fuzzy, but that's
All right.
okay, Richard.
Yeah, I can't help that. That's just that's just me. You know, I break cameras, I break mirrors. You know. No, it was like something really dumb, but had to be done. So I had a Schatzki's ring, so I had to be dilated.
Oh, no.
And so, no, it's okay. It just had to be opened. And so I just got back out. I mean, a couple hours ago, I just got back home. So.
Oh, my gosh. You're amazing, Richard. Thank you for joining us on your medical recovery bed.
It's so bad. No, I'm totally fine. Totally fine. It's just something silly. It's just like it's a silly thing, but you know, that's why I'm just not in the office. So,
Prof, can
Well,
you wait a bit for
we
Dr.
have,
Surapon?
Go ahead, Wanapa.
say that again?
Could you please wait for Dr. Surapon a little bit? He is not yet in.
Okay, well, we could talk about some other things. I put together, I mean, again, this is I try to make something that maybe he'll be interested in seeing, which is, or the scientists will be in this, huge advancements happening. And so I was going to try and show some science as well as some baseline stuff and how it's going to affect our practice, which hopefully sometime downstream will affect your practices. So, and that's what we're headed to. So our first visitor from, our first short-term, long-term visitor, you know, is coming from Thailand tomorrow, or yes, is already here today, and I'll see her tomorrow. She's the Dr. Pangadaporn, who is going to be learning how to do autologous transplant. She's a colleague of Dr. Mr. Gristle, and allegedly is going to be setting up her own auto program. And so he has asked us, and she's just arrived. I'll meet her tomorrow for the first time, and we have basically a 3-month plan for her. And Serpol joined, and Justin left, and then we're still working on another person to come this summer, who will be here for a year, and we'll focused on development of understanding what we know about CAR T and cell therapy. So yeah, I'm happy to be back with you folks. I look forward to, it is already February or almost March, and figuring out what we're going to be doing, what we're going to try to do for the year. I know we're going to try and alternate sessions. The last visit was presentations from your 3 physicians, and next time there will be another presentation from your team, perhaps an M&M, as well as another presentation from from Phi, our pediatric hematologist.
Hi.
And
Hi,
but
Prof.
I think
Dr. Surapon is in now.
Yeah. Okay. Well, I'll get started in a minute. I'm just saying. So, but I also think that I've been busy the last few months. It's just there's a lot of stuff going on, and but I want to sort of sort out what we're going to do and try and do as goals of the year, and to make sure that, again, I'm going to say again, I'm very motivated to put in energy into this activity. I really want to see it work and be successful. I have some plans, but I also want to make sure I dialogue with you folks along the way, and I'll figure out who is the key person and I will be doing that. So, comments before I start for today's educational session? Got background noise. I hope it's not from me. So I'm going to try, and if this works, I should be sharing. Whoops, where is the share? Hang on. You're sharing your screen, not the wrong one. Hang on. Share. It was working. It'll come. Where is the button that says share? Share content, and there's the talk. So do you see that? Do you folks see this? I hope. Hello?
Yes, yes, yes. We see it. Thank you.
Oh, okay, good. So this is like so last time I talked, which was, I gave like an update of the hematology meetings that took place, the annual American hematology meetings. This was again, you know, literally last week was the American Society of Cell and Transplant and Cell Therapy. And I spent a week out of town, and but it was actually, sometimes some meetings are better than others, and I think this was, you know, pretty exciting for the future. And I'm going to try and capture some of this. Some of the science is even well beyond what I do, but I just think it's worth talking about the science because it is going to dictate, you know, pathways to the future. And so I was going to start with, come on now. You're sharing. Next slide. There it is. So the first thing we're going to talk about is where that a lot of the big news this past week is that they're now getting cellular immunotherapy outside of blood-based cancers, and they're learning how to do it effectively. And so there's a whole host of complex, you know, interactions that are needed to successfully perform solid tumor cellular immunotherapy. Part is identifying target antigen, figuring out how T cells can actually penetrate. You know, there's issues of, you know, increasingly identifying T cell receptors that may be specific. A lot of times I could say that the solid tumor malignancy, a lot of the patients are older and have a poorer performance status. And so there's also issues of, are they going to be able to live long enough, maintain a good enough performance status to be able to tolerate therapy? Again, currently, most of the trials and it's almost all trials, and I'll clarify that, are limited to academic centers, so we haven't really done real-world assessment. And we do know, like I can tell you, screening is, and I'll show you the studies we have open. We have a study right now for overexpressed HER2 malignancies, which should be, you know, GYN malignancies, gastrointestinal, and breast malignancies. We have screened probably a dozen people, but they have to be 3+ HER2, and a lot of them are 2+, and they don't make a high enough antigen expression to be eligible for the trials. And so we're seeing a lot of professional effort goes into talking to patients that can't go on study. And then the big question is, how do you get patients? And this presentation, these first 5 or 6, 7 slides are going to come from a presentation that took place last Tuesday at the BMT CTN from a scientist who's a member of the Malcolm Brenner program and Helen Heslop program in Baylor at Houston. Next. And so one is, so I would point out that in the next evolution of cell therapy, there's no currently FDA or EMA approved, there has been no current approval for cell therapy for solid tumor. In December of 2022, which is 14 months ago, in the United States, the FDA actually approved a viral therapy. It's a gene therapy where they use a adenovirus to introduce basically a vector that turns on and expresses interferon alpha. So it's designed for BCG resistant superficial epithelial cancers, because when you basically you infuse the viral vector, it binds to the cell wall, the epithelial cell wall, brings in and transduces the epithelial cell. They turn on high expressions of interferon alpha, creates an inflammatory event, and treats superficial bladder cancer. And it's been FDA approved, and that was sort of exciting. That's a gene therapy, not a cell therapy. Of course, we have a host of cell opportunities. CARs are on everybody's mind. We know how CARs work. TILs have been looking around since the first paper in the mid-1980s from Steve Rosenberg. By the way, he just was granted the Lifetime Achievement Award. They announced it yesterday for the American Association of Clinical Research, AACR. There's macrophage monocyte studies, and currently at OHSU we have, we have slides. I have another slide about this. Sorry, where we have TILs, tumor-infiltrating lymphocytes for advanced melanoma, and as well as advanced colorectal cancer. We have CAR T cells for, again, the overexpressed HER2. The ROR1 antigen is a superficial antigen. It's expressed on lung cancer and triple-negative breast cancer. We have a ROR1 CAR T study. We have a Claudin 18.2 study where it's targeting gastric and GE junction malignancies, adenocarcinoma. Claudin 18.2 is an interesting target. It's on a lot of mucosal surface. Now, this is a case where we do have a complication of GI bleeding because you have a tumor effect, but you have also an on-target non-tumor effect because the gastric epithelium can be targeted. And so we have to get around that GI bleeding issue. We're about to open a Glypican-3 for hepatoma, and we may have a testicular CAR T coming, targeting a specific embryonic antigen, and then we're doing a transduced T cell with a T cell receptor that's specific for mutated KRAS, and that will be coming. So we have a lot of activity. If you look at solid tumor targets to date, it's vast. There's a lot of potential targets. And so, as I said, we've got 4 or 5 targets, but there's theoretically quite a large number of targets that could be, pursued. And by the way, and at 10 o'clock, NY-ESO-1 may be approved by the FDA. It's looking very positive that HLA-restricted T cells that will target NY-ESO plus HLA-A2 for synovial cell sarcoma. The preliminary data looks excellent. The FDA will be acting on that later this year. There's a lot of obstacles for CAR T cells for treatment of solid tumors. One is the tumor itself is large. It can be large, and it's often heterogeneous. Hematologic malignancies have a more homogeneous expression and a more homogeneity in the disease itself. The tumor malignancy is, this has much greater heterogeneity. There's certainly a lot of mutations that have been identified. For instance, a lung cancer typically will have 30-point mutations, so there's theoretically a lot of T-cell receptor targets. But to penetrate the tumor, there's a variety of cells that will give an opposition. There's, myeloid dendritic suppressor cells. There's tumor-associated neutrophils that will be creating inflammation, tumor-associated macrophages. The tumor itself will be trying to send signals to turn off the T cells, and a lot of times you will have T cell exhaustion. And so far, it's been promising, but not yet the answer. There are multiple studies now, that have been used. So these are a series of pediatric tumors, and again, that have been tested. You can see there's only a limited number of centers who actually are investigating and studying these, but still we're learning a lot from them, and the data are being shared. And basically they're developing the discovery And if there is a signal right now, a lot of companies are licensing their technology for widespread, exploitation and expansion. GD2 is one that's very interesting to a lot of people. GD2 is found on very common in neuroblastoma. There has been in the past an antibody and complement, treatment with high-dose therapy with antibody targeted therapy for GD2 in neuroblastoma. And this is an example of when they've developed a CAR T for that may see the neuroblastoma in the upper point. You can see they actually clear the disease. Below is a HER2, the EGF receptor can be often overexpressed in glioblastoma. You can see glioblastomas responding. And so we are seeing these solid tumors can create responses. And so when we look at GD2, the first study that came out of, the Brenner lab, they were all relapsed refractory neuroblastoma. They used escalating doses of CARs. They could definitely show that there was activation, but there was no clinical objective responses. Subsequently, a second group reported there were responses, and they could identify patients. They did demonstrate that myeloid-derived suppressor cells that were in the peripheral blood seemed to inversely correlate, which we think that there is a cell that can, myeloid-based cell that can contribute to inhibitory factors that can shut down. And what attracted a lot of attention, Meissner's group, which is Crystal Mackel's group, Meissner was the first author in Nature, they looked at diffuse intrinsic midline glioma, and specifically, this has a overexpression of GD2, and there was 4 children. 3 of the 4 actually had the mutated diffuse midline glioma. 3 of the 4 had clinical and radiologic improvement. Again, when you actually look at it, were they cured? No, but did they change the natural history? And the improved progression-free survival was identified. So what do you need to activate T cells? Well, one, you basically need a target cell that will, and it could be a T cell receptor, it could be a CAR T, but typically this is what you need if you're going to develop a T cell response. You need a specific T cell receptor that will see peptide plus MHC. You have to have co-stimulatory signal, and obviously, that's where the checkpoint inhibitors come in to block off signals sent by the tumor. It's also increasingly recognized, though, that the T cell cytokine receptors play a major role in the amplification and the maintenance of the T cell, clinical response. And that has been under-recognized. I think the use of IL-15 has attracted a lot of attention because it does seem that if any cytokine can overcome T cell exhaustion, it's going to be IL-15. And recognizing that, there's a host of now new molecules coming out that people are using to, hopefully improve function. They're genetically modifying cells to, enhance cytokine-like expression. So these are what they call the armored CARs. So the actual creation of the CAR construct includes, for instance, the expression of a cytokine gene. Also, there's ways to, they're creating switch receptors. So like IL-7 is known to not be present on mature T cells. It's there early on in development, but if it's critical for thymic development, but people are making like combination receptors so that you can actually use the IL-4 cellular machinery to activate the T cell with exogenous IL-7. And so this is what they made it, for instance, this is one of the examples of the study. This is, was presented, these are data in plenary talk from last week. So here's what happens typically on the left. You have IL-7 comes in, you may bind an IL-7 receptor, and you cause STAT5 signaling. What this group has done, and they show, is you can actually make an ectodomain, so you can have an extracellular CD34 expressing domain. And so that actually helps because you can then, when you decide to develop your CAR T, you can also test with like CD34, CD3, and you look for the co-expression, and you say, oh, wow, it's perfect. I know how many cars are in circulation. But what they did here is use the ecto domain, but they created a disulfide bridge in the transmembrane domain, so it forces the binding, creating the dimer. And once they create the dimer, you get the STAT5 signaling turned on. So this is a way to make your cars have constitutively, be activated and hopefully not turned off or exhausted when it comes to the CAR T. And does it work? Well, what people are trying to do, this is a clinical trial where what they're doing is they're using EVV, specific T cells, because that will also theoretically create an inflammatory signal that will then enhance the ability of the receptor to work and be activated. It does appear to be safe, and these are patients who've done this, and they've now used this in the case of, Dr. Omar was also with Helen Heslop's group. They've added this to CD2, that the CD7 receptor expression didn't actually amplify and make a T cell overgrowth. It didn't transform the T cells, but what happened is they actually started to get clinical responses. You could see 9 of 14 patients did have CRS, and they're seeing in the imaging, you're seeing some clinical benefit. So this is the foundational studies. They're getting just started. Similarly, people are investigating using IL-15 and how you can get IL-15 into the CAR cells, because if anything will overcome, exhaustion, it's going to be IL-15. And this is the construct they use. Finally, I thought this was interesting. There was a presentation using, oncolytic viruses is another thing that attracts attention. I got invited. I'll be giving an oncolytic virus talk next month, and maybe I can share that when I finally produce it. What is the status today of using oncolytic viruses in treatment of cancer? But this was a case that the second line is important. You come in with the virus can infect cells, but it will actually turn on, make a cold, tumor turn immunologically hot. It will express viral antigens, and then it could attract immune cells to that target for destruction. And what they showed here is in the on the bottom right is you can see the oncolytic viruses in the blue. Whether you look at the expansion of the T cells or the likelihood of, this is an animal model, the animal survival. The only animal that survived when a tumor challenge is when you gave the CAR T cell that may target that particular, in this case CD19, but also with the oncolytic virus causing an inflammatory signal that would then amplify the ability of the CAR to get to treat the peritoneal metastasis. So again, new experiments, new science. And so I already said this. We do have a host of solid tumor studies that have been, recruiting over the past year, and we're starting to put patients on. We're actually getting a lot of patients referred for the Claudin 18.2 study. I just had a young patient referred with gastric carcinoma yesterday, and we're hoping to be able to share data about this, our own experience, probably in 6 to 12 months. What about TILs? So this is the breakthrough. I think you may have heard this in the scientific news, maybe not all of you, but these are tumor-infiltrating lymphocytes. As I said, Steven Rosenberg in the mid-1980s, so that's nearly 40, that's over almost 40 years ago, started investigating actually what are the T cells that migrate directly to a cancer, because those cells theoretically should have the T cell receptor. Of all the millions of T cells that you have with different clonotypes, those are the T cell receptors that should see the tumor. And if it sees the tumor, those are the T cells that should be able to eradicate it if you ever could figure out how to, handle them directly. The trouble is once the T cells get to the tumor, they rapidly are overwhelmed by a rapidly growing malignancy with inducing tumor, T-cell exhaustion and tumor tolerance. And so what they did here years ago is they take out tumor. They did this at the NIH, so it's government-funded research that most of us couldn't do in academic centers because you just spend the money. And so they identify the tumor, fragment it, purify the T cells, expand them in the laboratory, and reinfuse them. And so there were anecdotes that showed benefit, but there's really been a lot of the work for the last 15 to 20 years has been, how do I maximize the conditions that those exogenously generated and expanded T cells, when reinfused back in, can have a clinical response? And so here's a paper published in JITC a few years ago on TILs. And you can see that, these are the patients, about 10 patients. 2 patients had clinical responses that had, that are sustained and even into clinical remission. So 2 clinical remissions out of 10, but 8 out of 10 with a response, just not sustained. And in there, this is from the paper, you can actually see the cutaneous burden of the melanoma prior to TILs, 3 weeks after, 2 months after, and 3 months after the person gained a clinical remission. And subsequently, lifileucel, which has now been developed by Iovance, which was they licensed the technology to run this, and they ran a phase 2 trial, open label. You have to have had prior therapies that help a melanoma patient, which are BRAF inhibitors or checkpoint inhibitors, and they have to have failed both. So this is third-line melanoma. Most of those patients, when we treat them, they die pretty quickly. Melanoma can be a very rapidly growing malignancy. And here's the data. And the data showed that a vast number of people responded. You could see the cut mark for complete, for partial remission, complete remission. What's important is if you look at the ones without any black, those are the patients. There's 1 patient with CR, a lot of patients with PR. But if you were a responder, the duration of response had not been met, and the median duration was not met at 19 months. Well, these data were submitted to the FDA for a biologic license approval. Well, on February 16th, so literally we were there, it was like the day before leaving for the meeting, the FDA they gave accelerated approval. This was ahead of the scheduled final PDUFA date for lifileucel, now traded name is Amtagvi, and it's a TIL. Have to have had failed BRAF inhibitors, failed checkpoint inhibitors, and what did they show? Again, this is the data. The median time to response is about 6 weeks, so you can't just give the cells and think it's going to be immediate like we could sometimes see with ALL. It's going to be a little slower, but overall response on 73 subjects now had an overall response rate of 32%, and the median duration of response had not been reached. So the FDA has granted this approval. Interestingly, that was approved on February 16th. In the United States, February 19th is a holiday. The first patient in the country for commercial CAR T was in the OR at 7 a.m. on February 20th to harvest melanoma to be sent for commercial production. That surgeon was actually flown into the stem cell meeting to talk about just nuances and first experiences about, what we all need to know when we offer this. I will tell you personally, I already have 3 referrals for hopefully effective, but commercially available lifileucel. And so we will be treating a number of patients with melanoma. What's scary is, to me, honestly, is I did 90, like I said, we did 91 CAR procedures last year. I think we are on for hematologic malignancies, we're going to do more than that this year. When you look at melanoma, they did the projection that there will be 18 RAF-resistant checkpoint inhibitor individuals out of every million people. So so theoretically, my ceiling is I could add 72 more patients to my clinical, clinical management team. We are the only site right now in the Northwest approved for doing TIL therapy. And I think obviously we're not going to get, 100%, but it's not unreasonable for 40 to 50% of patients to actually make it to referral. I just have to be prepared for another 35, new cell therapy patients coming to my program. What about safety? There was some progress, important progress in safety issues. So I was going to share this, is my colleague Matthew Frigault presented this at ASH. I will be giving the encore presentation at EBMT, which is, can we overcome cytokine release syndrome? I can tell you that there are CARs that we know 80, 90% of the patients will have CRS. We're managing CRS in the hospital. We can give a CAR in the outpatient setting, but when they get febrile, we put them in the hospital because we don't know how fast they're going to progress potentially into ICANS. And so going back a number of years ago, we know CRS and ICANS are common. CRS is an inflammatory signaling. Like, we know IL-6 is there, we know gamma interferon is there, but it's also important to recognize that intracellularly, those receptors, those extracellular receptors, when bound to their cytokines, activate through the JAK-STAT pathway. So Dave Porter and myself, this goes back about 8 years now. We approached Incyte, who had ruxolitinib as a JAK1, JAK2 inhibitor, about could we do a ruxolitinib study for CRS prevention. They came back to us and said, we think we have a better drug. We have a selective JAK1 inhibitor, which does not have the marrow toxicity that ruxolitinib has, which is a JAK1, JAK2. They did a series of safety studies in the laboratory to prove that it was beneficial, and then we took it to clinical trial. We had a very short dose escalation phase 1 that seemed to give a signal that itacitinib was going to be effective. We start this on day -3, 72 hours before the CARs go in. It continues to day 26. It does allow for patients to be treated as an outpatient. We actually had the patients wear what's called a TemTrack device. It's a little disc that it does 24-hour monitoring of their fever or their temperature. They put it on under the armpit, on the skin on the left flank, and they wear it. And so we're constantly being able to get real-time monitoring for temperature. So the preliminary data looked promising, so we said let's move it up to a phase 2 study, which is using the dose 200 milligrams twice daily, and it was a randomized double-blind placebo against a commercial CAR, which we know causes CRS. It was only patients getting axicabtagene autoleucel that were allowed. So you can see the eligibility of we're going to focus on part 2, adult patients. It had to have a good performance status. And it was going to be, again, we're looking for a signal. This wasn't registrational, 23 patients per arm. They either got itacitinib twice daily or placebo twice daily. And the primary endpoint was, can we block progression beyond grade 1 CRS? And secondary endpoints are going to be, how long was the duration of CRS or of ICANS, and a host of other safety markers. 42 patients completed treatment. The patients who didn't complete treatment, so we enrolled 47, most of them were disease progression. When we have a physician decision in placebo, that was likely due to probably disease progression, but they didn't declare it as such. Adverse events for discontinuation was equivalent. And there is, a mild, very well tolerated, not much nausea. And so when you look at the demographics, I will tell you they're pretty equal. They're all, there's a little higher rate of primary refractory disease in the placebo group, but otherwise, same number of patients with prior autologous transplant, 2 patients with a prior allogeneic transplant with itacitinib, and most of it was large B-cell lymphoma with only 1 patient with transformed follicular. What we saw is if you look at CRS by day 14, there's a statistically significant improvement in the reduction of grade 2 or more CRS. You can notice, if you look, the grade 1 CRS in placebo was 30% and almost 50% in grade 2, and 50% in the itacitinib arm. By the way, an important caveat, the patients on the study, they did not, if they got fever, if they got CRS grade 1, we did not start tocilizumab. We did not start steroids. There was no intervention until they were either they progressed to stage 2 or it was 72 hours had passed. So what we do see is significant reduction in advanced degree of CRS. And if you look at the duration of CRS when they got greater than grade 2 was equivalent, but the interventions, there was far greater number of patients who were on the placebo who ultimately had to receive tocilizumab or dexamethasone for rescue. And this was another new, you always have to think of new endpoints. So we looked at a CRS-free survival at day 28, and you can see in the picture, placebo versus itacitinib is 70% CRS-free survival in the patients who got itacitinib for grade 2 or above versus only about 25% for placebo. So when it looks at ICANS, to me, this is the most exciting. When you look at ICANS, now the study was not powered, but it was observational it was designed for CRS protection, but it was designed to be observational for ICANS. But there is a significant reduction in the number of patients who developed ICANS, advanced ICANS. You can see only 2 patients in the itacitinib arm got advanced ICANS, while it was a much higher percentage, 35% of patients in the placebo arm. So the overall response rates, this was important safety signal. If we're given a drug that cuts inflammation, by any chance are we hurting the tumor response? And basically across the board between placebo and study drug, absolutely identical statistics, maybe even favoring a little bit the itacitinib arm. It's not statistically significant, but the fact is no negative impact on the CAR T management of the disease. So it's a well-tolerated regimen. It's promising, and right now we're designing a registrational phase 3 study. So that's a safety measure. So that's I think a positive progress for safety. What about other stuff? Well, I may have shared with this before. We're always worried that the CAR Ts, they are genetically engineered. The FDA is interested and worried that potentially the CAR T could be causing a genetic mutation that, the viral integration could be transforming. So this was a paper published 5 years ago now from Carl June's group, where it was a patient who got a CAR T product, and then they got a reinfusion at day 70. And if you follow it, they were at 1 month, you can see that they looked at all the V beta families, and you have appropriate distribution across all V beta families of the T cell receptor beta chains. What they noticed though at the 2 months, when in retrospect they noticed at the 2 months, they were starting to get a overpreponderance of one V beta family T cell receptor, and then ultimately when they did the second, this was after the 2 months after the second infusion, and then so now we're 2 months post, that was whole blood, and that was whole blood. So if you actually purified the CARs, you actually could see they were 100% a single clone. And what they ended up showing is that was a CAR T that intercepted between, one of like exon 10, exon 11 of TET2. And that, we know TET2 is a mutated TET2 is often seen in CHIP. It gives clonal proliferation. And what they have is a clonal proliferation of T cells. they never met the criteria of being a T-cell malignancy. It was a clonal proliferation, but they never developed T-cell lymphoma. And there were people proposing, hey, this is what we should do with CAR-Ts, is modify TET2, and then what we can do is make a clonal proliferation. It may give them an advantage, and this may be a future. And again, that's a clinical experiment. However, what happened is there was an investigation. They started to see in these patients, now a lot of patients getting CAR-T who survive do have prolonged immune suppression, and it takes time before you get your normal T-cell repertoire back. And what the FDA announced, and they're constantly collecting, we are mandated to follow patients for 15 years, anyone getting commercial CAR-T. And if we get the commercial CAR-T, we're there to report any second malignancies. I've already had a patient with lung cancer. We sent the lung cancer out for, testing. There was no CAR-T. We've had a patient with prostate cancer. No, we're just doing our job. Well, what happened is they saw there's now 22 patients. I thought it was 23. I went back and checked. There's 22 patients who developed T-cell lymphoma. And so now the FDA is demanding when we use commercial CAR-T, with 6 commercial products, that we are mandated, we must report to the patients in the informed consent that there is a risk for T-cell malignancy. Now, there's a recent paper, I'll get to it. There's a recent paper where they said if you look at what the risk is, if you think it's over 35,000 patients have received CAR, many patients are now cured when they wouldn't have been. The risk-benefit says still go with the CAR, but we just have to notify patients. So this is one where this was what alarmed people. This came out at ASH, where they showed that someone getting cilta-cel, ciltacabtagene for myeloma, that those patients actually could show a integration of the viral vector into an oncogene called PBX2, and that led to tumor monoclonality. These patients got T-cell lymphoma. There was a facial lesion growing, and it was biopsy proven to be T-cell lymphoma. So there's now, as I said, I think it's 22 cases, not 23. I added wrong. This at the time the first report came out, it was 12. Now it's up to 22. And one of the late-breaking abstracts was a very detailed molecular analysis of a lymphoma that got T-cell lymphoma, and where they could show absolutely, without a doubt, there was no CAR-T, signal contributing to the lymphoma. So proving that it isn't CAR-T damage is also important. We have now identified in our own series of, now we treat almost 150 to between 150 to 200 patients with CAR-T. We have one patient, a peripheral T-cell lymphoma. The patient got tisagenlecleucel. We have interrogated that, and there is zero evidence of CAR-T, invasion of that T-cell lymphoma. Colleagues at the University of Kansas, they have a tisagenlecleucel patient. They have a T-cell lymphoma. They're doing the same interrogation. We plan to report those, as a joint contribution. And like I said, the editorial by Bruce Levine is about answered questions. So it's 5:45 my time, 8:45 your time, or 7:45 your time. I saw that Serpol is off the line, so I probably will skip this because this is really cool basic science, but I think he would be the one that would appreciate this the most, where you're now mapping, you're designing molecules that could be CAR-T products. This was a plenary session on what we call now epitope editing. And so there were several works and very interesting studies, but this is it. And then, and they're now targeting AML. Like, this has been the big issue. Got it, Dr. Wanapa. So the AML is always the one, that's the one CAR situation we haven't solved yet, because you give the CAR, it kills the cancer, but it kills the bone marrow. What they've now done is find the binding site of CD45 as a pan, immune marker. They actually found the binding site mutated, they found where the antibody binds. They went through a series of genetic modifications, and they found they created a mutation where the antibody won't bind, but the molecule maintains its function. So now they're epitope editing hematopoietic stem cells. And then they can treat a patient with CAR T that'll kill the leukemia, but then you can come back with a stem cell graft that has a CD45 epitope minus gene, so that you still get the gene that allows hematopoietic growth, but you can cure leukemia and you will not destroy the bone marrow. This goes on. So I'll skip microbiome. I'm running out of time. I was going to say, what's the next future CAR T cells? I think the next one's likely, like I said, there may be a T cell receptors for synovial cell carcinoma, but we are likely to have another adult ALL study. This is obacaptogene autoleucel, and this is a very interesting molecule. And the key is, and I'll just go really fast here, when T cells bind to a tumor, they bind and they hang on for 5 minutes, 10 minutes before they disengage and go off to another tumor. And that has been shown to be partly contributing to the complications of cytokine release syndrome. Well, now the company, this is a group from Martin Poulet from University College of London, developed this CAR, and it's now been developed and licensed. And what it is, it's a unique CAR, but rather than stick and adhere to a tumor for about 5 to 10 minutes, it literally binds, hits the tumor, delivers a death signal, and is off within a minute. So you get many, many more hits against the tumor. And it seems that as a consequence, we're not seeing, what they're not seeing is an amplified inflammatory rate. So they see much lower cytokine release syndrome. The key here is they do split dosing for acute lymphoblastic for leukemias. And when you infuse leukemias, the cells are immediately hit the bone marrow, and the disease is in the bone marrow. And so what they found is if you give a single infusion like we do for most CARs, that you can actually create an inflammatory signal. They're trying to avoid the inflammatory signal. So they give a low dose on the first day, and then they come back, several days later and give a second dose. And so that's part of the dosing schedule. And what they have is, I'll just skip this. They treated 36 patients. But importantly, if you look on the right side, they now have a median overall survival at 15 months, projected 3-year survival of 40%. And again, the plateau on the right hand of the Kaplan-Meier curve suggests cure. So they are durable. If you look at the green, these patients aren't just short-term. These are the ALL patients, relapse refractory ALL. They basically die within 3 to 4 months. And now we're seeing, similar to what's already been shown with brexpiprazole and tisagenlecleucel, but with higher rates of CRS and complications, we're seeing durable responses that we think are curing patients. So I'll skip this piece, close that, and I guess I had too many slides here. It's safe and it's effective. Oh yeah, this is just fancy stuff. For you in the audience, we know HIV infects T cells, right? I mean, we know that's how AIDS happens. The HIV, the lentivirus, has receptors that allow it to bind to the CD4 cell. It gets in the cell and it grows. Well, there's a company that has now licensed, and it's called Vivavec. It's called Umoja Biopharma. This is also really cool science. They have a lentivirus where they've taken out the replication machinery so the virus can infect T cells. And then what it does is, this is the construct. So on the upper part, it shows they got CARs on it that sees T cells. You do have a CAR, and you have the glycoprotein that allows it to bind to a target cell. It's got a capsid, and it's got a gene. Now that gene is mostly the CAR. And what's more is you have it, it's generating CD19, so it can be used to treat the, it can be used to treat the, like our B-cell lymphomas or B-cell leukemias, but it also has a rapamycin promoter. Rapamycin is also sirolimus, an mTOR inhibitor. They created a molecule, they created a part of the molecule that will block the binding of the mTORs, intracellular signaling, but it will express the rapamycin receptor. So what the company's proposing, we may be joining them in a clinical trial. It's brand new. We will infuse patients with virus capsules. Remember we're talking about oncolytic virus? This is an oncolytic, but it's a virus capsule. We will infuse them IV with viral capsule. We'll let the virus capsule infect peripheral circulating T cells for 3 days or 4 days or 5 days. And then after that time period, we'll tell them to take oral rapamycin, oral sirolimus. Sirolimus is a rapamycin named drug. They'll take it. That will turn on the molecule. It'll turn on the CAR, and it will generate CAR T cells in the human body, not in the laboratory. Very cool science. This is the future. And so that's how I was ending. I think this was a meeting. This meeting was very clinical. I focused on the visions of the future, the meetings, where are we going to be 3-4 years from now? And I can tell you the science is overwhelming. So thank you. And I think I'm done for today on that presentation. And I'm certainly willing to answer anybody if they have questions about what you just saw.
Thank you very much, Prof. Congratulations for being the only first center in the Northwest to be able to do this for melanoma, right? That's really tell a lot about your stellar performance. Dr. Nutra, you have a question for him for this T cell, CAR T cell?
No, not yet. But it's me to more understand cell and
Yeah, I know. And like I said, I made this a scientific presentation because I just felt that, sometimes as opposed to pure clinical, sometimes it's really good just to know where we're going.
yeah. Thank you so much for a good presentation. Yeah.
I think I am glad to see that T cell is now broadened more and more to many cancer varieties. Now melanoma, and I hope that in the soon future it will be everything.
Maybe even
Yeah,
HIV.
Yeah, I saw the way things go is like the new hope in the horizon for a lot of cancer, whereby we kind of a lot of patients die from conventional chemotherapy in the past, and now with more targeted therapy like this, it is increasing chance of better life and less suffering from the side effect. So is
you're
there
right.
any...
What I was going to say, we're excited about is there's one of these T cell studies and we'll have 2 T cell studies for pancreatic cancer, where
Wow.
we all know that you can't do much at all for pancreatic cancer. There's one of the studies has already put patients into clinical remission, and we have another that we think is going to be able to shrink the disease, and again, hopefully change the natural history.
Can I ask a quick question, Richard, in terms of including BDMS with future clinical trials, looking at HIV even and things like that? I mean, it's exciting to work together, but also maybe do some trials together to expand the patient populations we serve.
Yeah, Justin, that you read my mind, because our Dr. Surapon, he is very capable researcher himself. So I think
Yeah.
pairing between you and Dr. Surapon will be a great pair. So whatever the cancer try that you both see the promising promising work together, I think that would be exciting. And I would hope that, because nowadays CAR T cell is like most are the Western cancer kind of things. So if you do something with us, you might want to look at something that we have quite good number, and you have some number, so that we can have the joint trial together. I'm just humbly think like that.
No, no. I have actually, as I said, when I started this presentation, I just said I really want to sit down and really, this is still exciting. The working with you all is a really excitement for me. It's just trying to, how do we change Horizon? How do we create access? I know Dr. Surapol has already treated his first few patients with CAR T. He's sending 2 of his trainees to work with us, so we're going to be, which means that when they go back, they're going to know what we know. And I mean, you already have your team members who've spent a week with us. These are people, and I've actually reached out to one of the companies, and one of the companies is at least willing to entertain, and again, I don't know, I got to figure out the finances, but if they may be willing to let patients from your program come for experimental CAR to OHSU. Now, they would provide the CAR would be free, but and again, I know you have patients who self-pay partly or help pay for their program. The company would not support their care in Oregon, but we can get the costs down, and within 30 days, we could send them back to Thailand, and all follow-up will be done in Thailand by Thailand physicians. The company is interested in trying this because
Prof, you don't
and I
have to
just
wait
said
and sit down.
What's
You
that?
can email. You don't have to wait to sit down with Surapon. You just email what you said right now to us, and we will pass that eagerly to him right away. Thank you.
Okay, well, that's what we like. I met with them again last week, and that company. I started talking about this after the hematology meetings in December, and then I met with them there, and I talked with some of your colleagues here last time, but then I went back and met with them again, and they really are interested in the concept. It's never been done. There's a lot of hoops to be passed, but if we can create that we're doing this collaboratively, they already support multi-center studies. They're not going to at the moment, they're waiting for registration for the United States. And until they get registration, they're going to be a little bit, cautious. But as far as, if we can find the patient from Thailand who can come here for about 35 days, I can do the CAR and then send them back. I do know that same model is in place right now in Costa Rica, where Costa Rica, they're not developing their own CAR, but they're working with one center in the United States where they identify patients who are eligible. The country is supporting that, the cost of care, the transfer, it's the cost of standard care. So it's the cost of cytokine release syndrome, the cost of neurotoxicity if they get it. The trial that we're working with has very low CRS, low ICANS. It's an opportunity for us to explore.
Excellent. And it would be good to publish on this too and have BDMS that have also showcased this for Thailand. Yeah. Thank you, Richard.
Hi. Yeah. So from this, we hope you can send us some short note to the email for Dr. Surapon regarding the joint clinical trial, the way or the style that you just mentioned with the CAR T vendor involved with the care. The last things.
Well, hearing your interest, I will go. But hearing your interest, I will go back to the company and say, we've got a thumbs up from BDMS that they're interested in pursuing this, so we could start to work out the details. Let's see because again, we need that company partner, and I think we could do this, and it would be
Richard, we might want to send it by email first and get Surapon. Don't you think, Wanapa, to give?
Yes. To get Dr.
Sure,
Surapon.
I'll send a note. I'll send a one-on-one email to Surapol.
That'd be perfect. Thank you.
Prof, could you please don't forget to send us the questionnaire?
Yeah, I was going to say, if you could, yeah, please, I will. If you could just send me back, just to put the names on the top and what their discipline was, like nursing, pharmacy, And if you that would be a big help. Just put the name in, like, MD, RN, PharmD, and then once I have that, I'll fill it out.
Yeah, Jenny, thumbs up already. She will do that.
Thanks,
And
Jenny.
also,
And I'll tell you,
a few,
and I think
yeah.
you already know the answer. I think you already know the answer that my entire team was totally, thrilled by the opportunity to work with your team members.
That's wonderful.
Yeah, and the other thing for Justin to help with check with Dr. Nemesek regarding those documents that Smith asked for it.
Okay, I'll figure that out.
Yeah. Thank
Sorry to
you.
keep bothering. I'm sorry to keep bothering you, Richard, but I'll keep sending on the emails. They're very good about follow-up. So I know that hope you're not annoyed by those, but we'll
Yeah.
keep reminding you.
Sorry for our nagging behavior. It is in the
No,
blood.
no, it's not
Cannot
that.
change.
Actually, since your team was here, Dr. Nemechek got a promotion. So she's now going to be the associate director for the Cancer Center for all clinical research. And I always say pediatricians have the time. I know we have pediatric folks on the, as opposed to, they do 30, we do 300. But no, I'm really pleased for her. So that's what she's been distracting, but I'll make sure I get back to her, and I know she'll take care of that.
Thank you, Richard.
Thank you. We reached the time. Thank you very, very much. And please don't forget to send us the slides. Thank you.
Thanks,
And-
everybody.
And
Thanks,
your
Richard.
lecture will be on the CME online for the credit as well. Thank you.
Thank you so
Fascinating.
much.
Thanks,
and
Richard. Great
bye-bye.
job.
Have a good day.
Bye, everybody.
Bye-bye.